hope you're all doing good. So in this video, let's focus on the following topics, starting with a case-based question pertaining to unilateral headache. And I guess these were the options: trigeminal neuralgia, cluster headache, migraine, etc. So if you look into the question, they might have asked you, or they might have mentioned the age of the patient, the sex, etc. So based on the given keywords, I think migraine might be more appropriate answer. So let's anyways review the clinical features of various options, including that of migraine. So if you observe migraine, it usually begins during second decade of life and is especially common in professional persons. Migraine headaches are reported to affect women more than men. The frequency of attacks is extremely variable, right? And also they mentioned about the quality of pain. The pain is usually described as deep, aching, throbbing type. And also you can review the clinical features of other options as well and decide accordingly what the appropriate answer is based on the question you faced in exam, right? Now let's move on to the next question. Drugs associated with neutropenia, or which of the following drug doesn't lead to neutropenia? So I'm not sure what the question is, but based on the keywords, here is some literature for you. Just review it once. So there are various drugs which cause or which have the potential to cause neutropenia. Either it could be because of febrile situations or bone marrow suppression, etc. So phenytoin, anti-epileptic drug, as you know, so it causes neutropenia, which is rare, but when there is neutropenia, discontinuation of therapy is required. Ticlopidin, it's an antiplatelet drug which also rarely causes neutropenia. Various cytotoxic drugs, anti-cancer drugs also cause neutropenia, like take for example docetaxel, topotecan, irinotecan, etc. And also sulfonamides cause neutropenia, which is rare. Metronidazole causes transient neutropenia. Third generation and fourth generation cephalosporins, as mentioned, also cause neutropenia. Linezolid also causes febrile neutropenia. Zadovudin also causes neutropenia. It's a nucleoside reverse transcriptase inhibitor, as you know. Interferon alpha also causes neutropenia. Albendazole also causes neutropenia. So these are some of the list of drugs which have the potential to cause neutropenia as an adverse effect, right? Now let's move on to the next question. Pregnancy tumor. So I guess there was a question on the same. So gingival enlargement. Pregnancy tumor is histologically identical to pyogenic granuloma of gingiva, frequently occurring during pregnancy, and often has been called as pregnancy tumor. As you can see in the image, we have this well-defined lesion which appears about third month of pregnancy or sometimes even later, gradually increases in size, and after delivery may or may not regress. Right? Also, it's mentioned that there appears to be no justification for retaining the term pregnancy tumor, since lesions of an identical clinical histologic nature are seen in men as well as in non-pregnant women. So this is another interesting point pertaining to pregnancy tumor. Right? Now, moving on to the next question. Muscles of eye are derived from which embryonic germ layer? So if you review literature, there is plenty of literature available. So in one of the articles, it's clearly mentioned that as does cardiac muscle, much of the smooth muscle in the body arises from splanchnic mesoderm. Exceptions are ciliary muscle and sphincter pupillae. Muscles of eye which are derived from neural crest ectoderm, and much of the vascular smooth muscle which frequently arises from local mesoderm. And also in one of the other references, it's mentioned that the extraocular muscles are of mesenchymal origin. The muscles are derived from mesoderm, whereas the connective tissue components originate in neural crest. Their embryonic origin requires an interaction between the cranial mesoderm and migrating neural crest cells. So the summary is, the mesenchyme of head, including the orbit and its structures, are primarily embryologic derivatives of mesoderm and neural crest cells. The extraocular muscles originate from mesoderm, but the satellite and connective tissue of the muscle arises from neural crest cells. Most of the remaining connective tissue of the orbit also is derived from neural crest cells. right? Now moving on to the next question, thermoluminescent dosimeter badges. In fact, I did a presentation on the topic during my third year undergraduation under the guidance of my professor Dr. Samata, where I discussed various types of dosimeters, their potential applications and all. And when you guys gave me this keyword, it just reminded me of all those wonderful memories. So what are these TLD badges? What is the mechanism of action? So if you review literature, the TLD is a type of radiation dosimeter. The TLD measures ionizing radiation exposure by measuring the amount of visible light which is emitted from a crystal in the detector when the crystal is heated, and the amount of light emitted is dependent upon the radiation exposure, and you can find additional information here in the form of literature, right? Now let's move on to the next question. Which of the following types of injuries is associated with bleeding? So subluxation obviously seems to be a more appropriate answer. So if you review literature given in Grossman, subluxation is defined as an injury to supporting structure of a tooth resulting in abnormal loosening of tooth without any displacement. This is very, very important. The clinical features include the affected teeth are present in their normal positions in arch but exhibit horizontal mobility and have pain on percussion. Bleeding from gingival crevice is present, indicating damage to supporting periodontal tissue, and these teeth respond normally to sensitivity tests, which is another important point to keep in mind, right? Moving on to the next question, theorems of retention. So there are various theorems of retention given by Riddle. So as you can see, 10 theorems, of which 9 were given by Riddle and the 10th theorem was given by Moyers. So theorem 1, teeth that have been moved tend to return to their former positions. Theorem 2, elimination of the cause of malocclusion will prevent recurrence. Theorem 3, malocclusion should be overcorrected as a safety factor. Theorem 4, proper occlusion is a potent factor in holding teeth in their corrected positions. Theorem 5, bone and adjacent tissues must be allowed to reorganize around newly positioned teeth. Theorem 6, I guess this was asked in exam, if the lower incisors are placed upright over basal bone, they are more likely to remain in good alignment. Theorem 7, corrections carried out during periods of growth are less likely to relapse. Theorem 8, the farther teeth have been moved, the less likelihood of relapse. Theorem 9, arch form, particularly in the mandibular arch, cannot be altered permanently by appliance therapy. Theorem 10, many treated malocclusions require permanent retaining devices. So these theorems obviously are created or they're given keeping various experiences of practitioners in mind, and also based on several case reports, and obviously based on the observations of Riddle and Moyers. Right? Now let's move on to the next question, anchorage. So I guess reciprocal anchorage was given in exam. So anyways, do review this literature and also go through the following image. So what is reciprocal anchorage? Anchorage in which the resistance of one or more dental units is utilized to move one or more opposing dental units is reciprocal anchorage. Take for example, correction of midline tumor. Usually this term is employed where both resistance units are malposed and the dissipation of equal opposite forces tends to move each unit towards a more normalized occlusion, right? I hope it's clear. Now let's move on to the next question. I guess this image is that of a feeding plate. So anyways, I'll post you some images as you can see. So let me know if you need any additional information. So what you're seeing now, they are feeding plates, right? So feeding plates, as you know, they are prosthetic aids that are designed to seal the cleft and restore the separation between oral and nasal cavities. So this particular feeding plate is that of a particular case report. So Peary-Robin sequence where, as you know, it's a congenital condition involving combination of micrognathia, glossoptosis with or without cleft palate. So feeding problems are often associated with cleft anomaly, which make it difficult for the infant to maintain adequate nutrition. So the authors here present a case of 58-day-old neonate with Peary-Robin sequence in whom they constructed a palatal obturator for purpose of feeding, right? Now let's move on to the final question. There seems to be a question on traits, class traits, arch traits, etc. So as you can see, we have different types of traits. Class traits means common characteristics of incisor teeth. We call them class traits. whereas the major differences between maxillary and mandibular incisors, we call them arch traits, and the differences between central and lateral incisors of each arch, we call them as type traits, right? So I guess the question is pertaining to the form of the incisor teeth. So the labial lingual aspects of the incisors, they are trapezoidal, and the proximal aspects are triangular in shape. These fall under class traits or common characteristics of incisor teeth, right? So these are some of the topics which I wanted to highlight in this specific video. Again, do let me know if you need any additional information. Do let me know in the comment section. We'll review them and post them in the subsequent videos. I hope it's clear. Wish you all the best. Love you all.